this topic of addiction recovery and kind of what we're learning about it and from a theoretical and scientific perspective, and that's what I'm going to do. I'm going to kind of give you an overview from 30,000 feet, kind of where we've come from in the last 50 years, and why we are where we are now and where we're going to go. So I'll put you in the picture there. I don't have any conflicts. Just want to let you know, in case you aren't already signed on to this, but we do publish a free monthly bulletin every month, which summarizes the latest science. It translates it for the so it's digestible and easy to understand. So that's out every month. We publish that through recoveryanswers.org through our institute. You can sign up for it. It's free at recoveryanswers.org. So please do that and receive that in your mailbox, in your inbox. So this is by way of an outline of what I'm going to talk about. As I mentioned, I'll talk about kind of where we've come from in the last 50 years. Why the last 50 years? Because it's actually 50 years this year since the declaration of the war on drugs under Nixon in 1970. And that is significant because really that marked not just this kind of the rhetoric that we normally associate with the war on drugs, but it really marked a concerted federal national focus on addressing these endemic problems related to alcohol and other drugs. So I'll talk about kind of where we've come from in the last 50 years and where we are now, and what that's led to. I'll talk about this notion of recovery, what it is and why everybody's talking about it. I'll talk about a theory of addiction recovery from a biopsychosocial perspective and what we might, how we might be able to understand recovery in the process of long-term remission and recovery. I'll talk about some of the emerging services and the quality of evidence that we have for those services as they relate to helping people to sustain long-term remission and recovery. So, as I mentioned, 50 years, 2020 is 50 years from 1970, of course, and Nixon famously declared that drug abuse, quote unquote, was public enemy number one. And it really marked the beginning of a concerted federal focus, including large-scale appropriation of funding to affect not just supply, but also what they call demand reduction, which is treatment and prevention. And I think a lot has changed in the last 50 years. I think, number one, our rhetoric has changed. I don't think we would describe today drug abuse, quote unquote, as public enemy number one, but rather we would refer to it as the top public health problem in the country, as it is in most middle and high income countries around the world. As I mentioned, this really marked the beginning of a concerted focus at the federal level, which of course has been transmitted through the states around the country. But these federal institutes beginning with the National Institute of Alcohol Abuse and Alcoholism, founded in 1970 under that same administration. A few years later, in '74, NIDA was founded, SAMHSA and CSAT in the early 90s. And as I mentioned, these were part of a three-pronged approach, a multi-pronged approach to address problems. We want to reduce supply, we want to reduce demand, that is to say, prevent cases as well as treat cases of substance use disorder, and harm reduction also in terms of reducing overdose deaths as well as other kinds of harm such as disease transmission. And as a result of this spending that's occurred, there's been a number of paradigm shifts. And I'll take you just briefly through these. It's really a review of some of the things that we've learned, which has resulted in some paradigm shifts during the last 50 years, which will take us up to the present and what I'm going to talk about, which will be recovery. So, so what are some of these paradigm shifts? Well, I think one of them has to do with genetics and neuroscience. This has been a huge one in the last 50 years, with many, many studies looking at not just family history, but also genetics and specific genotypes and genetic polymorphisms, which can confer risk. These are important studies and important lines of research, of course, because substance use disorder, addiction, and substance-related problems are probably the most stigmatized conditions in many societies. When the World Health Organization, for example, has done studies pretty universally across different countries, illicit drug use comes out at the top of the list in terms of stigma. Alcohol addiction, which is the domesticated drug, of course, also is up there, number 4 in a list of 18 of the most stigmatized conditions across many countries. So when we think about the dimensions of stigma, there are 2. One is cause and the other is controllability. We tend to have more compassion for people and less stigma if we can say that they can't help it, didn't cause it, and they can't help it. They didn't cause it, that's genetics, has a genetic component to it, and then the controllability, they can't help it, has to do with the neurobiology and the neuroscience and what we've learned. So we've learned that about half the risk for addiction is conferred by genetics. And this has been very important to know because like other complex illnesses, genetics play a very important role in substance use disorder as they do in other psychiatric illnesses. And there's been a new field of pharmacogenetics, that is to say, the interface of medication with certain genotypes, matching a medication like naltrexone, for example, or topiramate for alcohol use disorder with certain genotypes, and this is showing some promise in terms of showing a good clinical response. The other aspect, of course, as I mentioned, has to do with controllability and what we've learned about this facet, very central feature really of addiction, which is impaired control, impaired inhibitory control despite severe consequences. And we've learned much more about the exact nature of this and how it affects the neurocircuitry of the brain through lots of imaging, functional imaging, structural imaging. And this has been a new area of investigation, which was only really accessible via autopsy previously to the last 50 years. And of course, this has meant that we've been able to see inside the brain as people recover. And you've probably seen images like this before. These are from the National Institute of Drug Abuse, showing that how the brain is impaired when it's exposed chronically to drugs, but then can recover when people abstain. And you can see on the right-hand side here that it's returning to normal here, looking like a healthy person at about 14 months. Doesn't mean someone's risk-free, of course, but rather the functional aspects of the brain are starting to return to normal. So that gives us hope, of course, in what we know and see that people do and can recover. In terms of psychosocial developments, of course, in the last 50 years, we've seen some very significant changes and ideas come about which have been helpful. One, of course, is the stages of change, which came out of an analysis of hundreds of different studies showing that people go through a process when they're about to change substance use behavior. And this has led the way, of course, to help us understand more about things that we can do to particularly address these early stages, pre-contemplation and contemplation. And this is important because many people come into treatment or are ambivalent about seeking treatment because they're not quite sure, they're not quite ready. They do and they don't want to change. And so new interventions, of course, have been developed to help resolve that ambivalence, most notably motivational interviewing, which has been a real paradigm shift. The idea here, of course, is that instead of thinking that people really need a good talking to, the idea is that people really need a good listening to. So it places the idea of patient motivation on the lap of a clinician. So it's now, it is now our responsibility as clinicians, if the person lacks motivation or is ambivalent, that we help them clinically to resolve it, especially given that it is an essential feature of substance use disorders. Another important paradigm shift has been relapse prevention in the 1980s, epitomized here by this quote, which I like from Mark Twain: "Quitting smoking is easy. I've done it dozens of times." So, of course, it's not the quitting, is it? It's how do people stay quit? How do you maintain the behavior change over time? And Marlatt and Gordon came out with this book in 1985, which summarized a lot of the science that had been done through the 70s and early 80s, looking at ways that could be used to help people sustain remission across time. And this was really the beginning of the notion of relapse prevention and chronic disease management. Contingency management is another one, that swift, certain, modest consequences can shape behavioral choices. Probably 150 clinical trials supporting this with strong effect sizes, that providing certain modest positive consequences can help people engage in treatment and do better in treatment. We've had, of course, medications, very important medications currently, of course, showing that with methadone and buprenorphine that can have the risk of overdose death utilizing medications. We have 3 FDA medications, of course, for alcohol use disorder as well. There's also been a recognition of multiple pathways to recovery. I think this is something relatively new in that a lot of us, our cultural mindset has been that if you have some kind of drinking or drug problem, you have to go to rehab. And this has been a kind of a cultural default, is that people go away to rehab if you have a drink or drug problem. When in fact, many people in our national recovery study, for example, we know about half of people recover, get into remission, resolve a problem without ever seeking any kind of external help at all. The ones that do tend to be on the more severe end of the spectrum, but there are different pathways to that same developmental endpoint of remission and recovery. The first ever Surgeon General's report, I was privileged to be a contributor to this, wrote the chapter with Keith Humphreys on recovery. But this is a nice, very nice document. It's freely available, it's patient-friendly, as well as just friendly for the general public. It's very well written, easily understandable, has lots of great graphics, and it just captures kind of what we've really learned in the last 50 years in 7 chapters. Based on etiology, epidemiology, treatment, prevention, and so on, including recovery. Which brings me to kind of where we are now in the paradigm shifting world of addiction, treatment, and recovery, and that is to say chronic disease management or addiction recovery management. And this is really, in my mind, architecturally defined and refined to a large degree by William White, who's depicted here. And Bill White, I've had the privilege of working with on many different papers, including this book. But Bill was really the architect, in my mind, of providing a lot of the conceptual framework and concepts and language that we use today in terms of understanding addiction as a chronic illness. And of course, it's not chronic for everybody, but it is for the kinds of people that we see typically in specialty care. And this is why. This timeline shows the lengthy clinical course to remission and even to stable remission. You can see on the left-hand side here that it takes about 4 to 5 years in adult clinical samples after the onset of a substance use disorder before people start seeking help. Now, why is that? Well, part of that, of course, is people want to try and do it themselves. They want to try and cut down. They want to try and stop. When they find themselves unable to do that, there's stigma, of course, involved in that as well. But as people find themselves unable to do that, or they're the interface with the criminal justice system or law enforcement, DUIs, etc., that can lead to treatment. After people start their first treatment, it can take about 8 years on average to get 1 year of full sustained remission and about 4 to 5 treatment episodes on average in adult clinical samples. So that's quite a long time. The good news in that period is that most of those days are abstinent days, but interspersed with those abstinent periods are intermittent relapses. And this is, I think, where we get the notion of a chronically relapsing disease from or disorder. But people are making longer and longer as they initiate a new attempt, there's longer and longer periods of sustained abstinence until they get that 1 year of full sustained remission, which is fantastic, of course, to get that first year of remission. But what's also noteworthy is that it takes 4 to 5 years of continuous remission before the risk of reinstatement or meeting criteria for a substance use disorder in the next year drops below 15%. Why is 15% important? Because that's the annual risk in the general population. So to be no more likely than anybody else of meeting criteria for a substance use disorder in the next year, if you've already had it, takes about 4 to 5 years of continuous remission. So risk is elevated even in that first 5-year period, and it can take many years to achieve that first year of remission. The good news is, even in clinical samples, 50 to 60% of people with addiction will achieve full sustained remission and recovery, even though it can take a while to do that. This graph from our National Recovery Study highlights this first 5-year period in particular. These are indices of functioning and well-being among people who have resolved a significant drug or alcohol problem in the United States population. It's a nationally representative sample. Across the bottom of this graph, you can see the number of years in recovery from 0 to 40 in this sample of 2,000 individuals. And then on the y-axis over here are these indices of functioning and well-being, including quality of life, happiness, recovery capital, which you can think of as recovery resources, and self-esteem and psychological distress, which comes down, of course, over time. What's nice to see here, of course, is that people get better, they function better over time. But what you notice is during that first 5-year period, that's where the slope changes here. The slope of the line changes right around that 5-year period. So there's this struggle in that first 5 years as people are finding their feet, they're getting traction back in their life and beginning to accrue those aspects of functioning and quality of life. What's slightly disheartening is that it takes about 15 years in the recovering population to reach the same quality of life as the general population. So it takes 4 to 5 years of continuous remission to be no more likely than meeting criteria for a substance use disorder in the next year, that is to say the same as the general population, but about 15 years to get to the same quality of life. And I think that's way too long. I think part of that is because as a society, we focused much more on the acute care models of treatment and not on the continuing care, and importantly, on helping people to build recovery capital that can help them sustain remission and have a better quality of life. I liken it to a burning building. We've become very good, as shown by those paradigm shifts, which have been acute care models. How do we stabilize people? How do we put the fire out? When we recognize there's an emergency situation, the building's on fire, we've become very good at putting out the fire. And that's where we focus most of our efforts, of course. That's critically important. But then the next question is, how do we refit the building? How do we prevent the fire from restarting? And this is where we've neglected, I think, a lot of our attention, which we're now focusing on, which is providing the building resources or recovery capital, the building materials that can be used to refit the building. And I think very importantly, the focus on building permits. Many people can't even start to rebuild their life because they have a prior drug felony or conviction, which prevents them from getting the building permit to actually start to build their life. They can't get a job, they can't get a loan, they can't go back to school because of prior drug-related convictions. So from a policy perspective, that becomes critically important. So we've come a long way in the last 50 years, right? I mean, we've learned a lot. If you think about it, when we zoom out, we've learned a lot about genetics, about cause, about controllability, about the true nature of these disorders. And I think that can help us understand more about what we see clinically when we see people struggling with recovery, that we understand it more clearly, what's happening. And we've developed a number of acute care models. And I think we're at the stage now where we're looking at how can we help people sustain remission and a robust recovery. So what is recovery? I'll just talk about this very briefly because people talk about this concept. Some people are trying to define it, operationalize it even, to measure it, which is difficult. It is culturally, it's both a process and an outcome. So there's lots of definitions, of course, about recovery being a process of adaptive change, enhanced resilience, and self-determination. But it's also an outcome. And many people will tell you that they are in recovery and previously they were not. So there's a categorical change also along the process of change where something happens where people start to identify as a person in recovery, but previously did not. So it is both a process and an outcome. And of course, you know, it depends on who wants to define it and operationalize it and whether we should. What's pretty clear is that just like the stages of change into early remission, there is a process and a stages, no doubt, in recovery. There is varying levels, of course, of incapacity that occur with addiction whereby people are under the control of the substance with impulsive and compulsive use, resulting in often devastating consequences in the severe cases, to the point where people achieve remission and self-determination, capacity for self-determination, self-regulation, and the ability to control their own lives. And this is important when we think about the appropriation of funding for recovery support services and how those should be structured and organized. I think most people would say that recovery is a combination of both remission and resilience. It's beyond remission, and a lot of people will tell you who are in recovery and advocacy groups that it's not just about the absence of the substance, but rather something that's been added. It's kind of the weatherproofing against relapse, which resilience provides. So it's beyond just surviving, but rather thriving. So what do we know about kind of, or what can we offer as a science in terms of understanding how people change and sustain remission, both achieve remission and then sustain it in those early years of recovery? As I mentioned, it can take a long time in clinical samples, the most severe end of the spectrum, to achieve that first year of remission. It can be a bumpy ride, but the majority of people do eventually achieve full remission and sustained remission, but it can take a long time. So why is it? Why does it take such a long time? Why is it so difficult to achieve remission and to be able to sustain it? Well, we know from lots of studies that have been done, as I mentioned, during the last 50 years in particular, that addiction is a complex disorder. It's what we call a multifactorial disorder. In other words, it's not just one thing. It's not your genes. It's not just your biology. It's not just the environment, but rather a confluence of different risk factors converging, including, of course, most importantly, is exposure to the drug. And depending on how old you are when you're first exposed, as well as the type of drug, the potency, the dose, the social support for drug use, all these factors influence the onset. And of course, drug exposure leads to changes in the brain through both neuroadaptation as well as through neurotoxicity. And those brain changes result in addiction. What's also interesting, of course, you see me change this, it's exactly the same, but I'm changing it now to recovery as a complex process. To make the point here that addiction is a complex process, recovery is a complex process also that involves our biology and genes, the environment, but different factors, of course. Treatment is important, stigma and discrimination, our cultural approach that facilitates the environment and the nature of the environment, whether it's supportive or not, to recovery. And then recovery capital itself, that is to say, the internal and external resources that can be brought to bear, including treatment, stabilization, acute care models of treatment, of course, but then internal factors like hope and optimism, self-esteem, meaning and purpose, empowerment, connection, as well as the external, jobs, friends, housing, income, etc., healthcare access. Again, these factors also change the brain, which can lead to recovery, of course. Now, we understand, as I mentioned, much more clearly about the neurocircuitry involved in addiction, that these neurocircuits of reward, memory, motivation, impulse control, and judgment in the subcortical areas as well as the prefrontal areas of the brain are implicated in the addictive process. And we can see that the functional aspects are result in structural changes. These functional deficits and changes result in structural changes as a result of chronic exposure. And you can see how down at the bottom right in particular, it's easy to see just the magnitude, the extent of that structural change among people with chronic exposure to drugs, in this case, alcohol. So when you look at images like that, it's perhaps easier to understand how difficult it can be for people to initiate a pathway of change and sustain change when the brain is so radically, oftentimes in severe cases, affected. We know that there are two major factors which influence relapse risk. One is sensitivity to stress, and the other one is a lowered capacity to experience reward. And this stress pathway and the lowered capacity to experience reward are fundamental aspects that have to change during that early period for people to be able to recover. So people have this endocrinological excitability in terms of corticotropin releasing factor and cortisol. Those are elevated early in recovery, which make people more sensitive to stress. And then the dopamine D2 receptor system is downregulated as a result of chronic exposure. As the brain has adapted to this abnormally high level volume of reinforcement, it's kind of downregulated those D2 receptors because of the overstimulation from the drugs. And so there's a period of adaptation or recalibration that has to go on in the brain with abstinence. And I like, many different theories. I think there's a couple here. One is the original theory by Hans Seeley from the 50s, which is the general adaptation syndrome. And then related to that is this notion of allostasis. And of course, our brains and bodies like homeostasis. You've probably heard the term homeostasis, which is kind of this balance, this equilibrium when we're kind of, we're not hungry, we're not thirsty, we're not upset, we're kind of in balance, and there's no drive, motivation to get up and do something because everything's functioning in a pretty balanced way. What motivates us is usually a deficit in some capacity or form that motivates us then to act to regain that homeostasis. Allostasis is maintaining that stability through change. That's what allostasis is. In other words, we change our behavior to be able to create homeostasis. It's that allostasis which facilitates the homeostasis. What Hans Seeley talked about was this general adaptation syndrome, alarm, resistance, exhaustion, shown here. I think this fits both with our notion of addiction as well as recovery. When we think about recovery, for example, oftentimes there is, with someone with a substance use disorder, there is an initial alarm reaction. There's an alarm that goes off. They might get arrested. They might have a fight with a partner. They may get kicked out of their home. They may get fired from their job. They may have something less dramatic, but nevertheless, it creates an alarm situation for the person, which makes them think very deeply about their substance use. They may actually say, you know what, this is it, I'm quitting, I'm going to stop. And there's a period of resistance. So people resist, they clench their fists, they hold on, they resist, they resist, they resist. Some people are able to resist and stop and change without any external help, as I mentioned. But in the more severe cases, that resistance can only last for so long without proper support. And that leads to exhaustion. And this is what Hans Seeley talked about. He wasn't talking about addiction. He was just talking about stress. Stress in organisms that produced illness and ultimately death. But I think it fits well with the notion of substance use disorder in that there has to be resistance at first, and that resistance needs to be supported enough and long enough for allostasis to occur, that maintaining stability through change. But when we think about it also on the flip side, on the addiction side, there is a similar process, of course, going on with active use. There is exposure to the drug, which alarms the brain that there's an abnormally high level of reward and reinforcement. The brain tries to resist that. It adapts to it. And it does well initially to adapt, but then it leads to not so much exhaustion, but a cascade of problems that results in a 180-degree turnaround from somebody who has found a substance which is the best thing ever to turns out to be the worst thing ever, the same substance. It's a 180-degree shift in the brain, mediated through the brain. And it's really depicted here. I think the reasons for starting substance use are the same reasons for stopping. Reasons for starting: to feel good, to feel better, to do better, or because other people are using a substance. And what are the reasons, four reasons why people stop? To feel good, to feel better, to do better, because now the substance is impairing their functioning and behavior, and because other people are not doing. That notion of role model inherent, of course, in groups like AA and mutual help and peer support. So we have these two processes which are inherent in this process of adaptation to recovery, the adaptation to the demands of recovery. So I think when we think about the theory of change, why is it so difficult for people to change, and then what can be done to accelerate that process? Now, is it inevitable that we have to wait 8 years for someone to get a year, or can we speed up that process? Do we have to wait 4 to 5 years before someone is at the same level of risk as the general population, or can that be sped up also by doing something? And the answer is a firm yes. We can do something to shorten that time. We know there are things that we can do to shorten that time to remission, and also to shorten the time to sustained, stable remission and recovery. And the question that I ask is, if addiction is a disease of the brain, could the kinds of services that we provide in recovery support services, friends who are in recovery, jobs, and housing, does that also change the brain, as I've alluded to in the model above? Well, it turns out that we've learned a lot from neuroendocrinological studies as well as neuroscience in terms of how those systems are altered by our social relations. So, in other words, friends, jobs, and housing can actually change the brain and our bodies, right? This is a meta-analysis, a quantitative review of 150 studies, nearly 300,000 people in this across all these studies. What they found is that social factors influence both stress and reward, as well as longevity. In fact, social isolation in this meta-analysis had conferred the same level of risk for premature mortality as smoking cigarettes. That was the magnitude of the risk. So there's been this issue of social buffering. We know that our social relationships provide stress relief for human beings as well as reward, right? We're very much involved with our friends and our family from whom we can gain support, and that helps us to feel better. But what is the mechanism through which that operates? And there's been now lots of work and focus looking at this area of social neuroscience. That is to say, how do our social relationships mitigate that stress access? And this becomes very important when we think about recovery, because, as I mentioned, people who have been chronically exposed to drugs tend to be hypersensitive to stress. So we need to find ways to mitigate that stress. And of course, a major thrust of many, many recovery support ideas, theories, and practical solutions have involved peers, most notably peer support, mutual help organizations like AA, as well as our treatment organization, or our treatment, including group therapy and other milieu therapies. What about reward? So that's stress. We know that social buffering can affect our neuroendocrine system that can help mitigate stress. What about social status and social support and the capacity to experience reward? So we know when people get into recovery, they have this kind of hedonic deafness initially. That is to say, they can't experience pleasure at normal levels. It takes a while, can take many months, maybe even years for some people, to start to experience the levels of reward that they once experienced pre-morbidly prior to the onset of substance use disorder. And we see here that there's a relationship between a correlation between social status and the level of these D2 receptor availabilities and social support. You can see a nice strong correlation, that line depicted by these lines, that show that the higher the level of dopamine D2 receptor availability, that is to say the capacity to experience reward, is correlated with both social status, and you can think of social status as access to resources, as well as social support. More social status, the more access to resources one has, the higher the capacity to experience reward, as well as the more social support you have, the higher the capacity for someone to experience reward through these dopamine D2 receptors. So those are correlational studies. So we don't know which way they go. Is it that people who have higher levels of these D2 receptors, for example, are more likely to have friends and more likely to have access to resources? Or does providing resources and providing friends increase that way around? Does it cause people to have higher levels of dopamine D2 receptors? Well, this is a study they did with primates to look at that. And they actually isolated monkeys who like to be, they're primates like us, who like to be with each other. They also like cocaine, like humans. What they did was they isolated the monkeys and measured their dopamine D2 receptors. They were isolated for about a year and a half, individually housed. And then they put them together in group housing, okay? And then they measured their dopamine D2 receptors after they were reintegrated with other monkeys in group housing. What did they find? What they found, interestingly, was that there was an increase. There was no difference in the dopamine D2 receptors when they were individually housed, but when they were group housed, there was a substantial increase in dopamine D2 receptor density for those monkeys who were dominant, who had access to resources. So interestingly, those who showed that increase, the dominant monkeys who had access to resources in these troops, had a lower risk of relapse to cocaine. It was explained by that increase in dopamine D2. So what does this mean for human beings? I think the human implications are that providing greater access to and availability of recovery capital, that is to say access to resources, may not only instill hope and empower people, but help them to have more control over their environment and increase their social contact and social mobility through the environment. And part of the reason why is because of these neurochemical changes that go on inside of primates when they're exposed to other social groups like peer support, AA, sober housing, and so on. So historically, of course, there has been two major ways that most societies have addressed these endemic problems related to drugs and alcohol. One is through professionally directed treatment. The other is through peer-led, community-based mutual help organizations like AA, NA, Smart Recovery, and the like. More recently, there's been an addition that has come along, what some people call the third tier, or an additional tier, or additional dimension characterized by recovery support services. And these recovery support services encompass a multitude of things, including recovery community centers, recovery residencies, recovery coaching, recovery in education. But what's interesting is that our concept of SUD treatment is actually changing. This is actually from the NIDA website, National Institute of Drug Abuse website. And what you see here is a model of treatment. You can see here that it says at the bottom here, the best treatment programs provide a combination of therapies and other services to meet the needs of the individual patient. What's kind of interesting to me is how this has changed from one that's been more focused purely on clinical services to one that is now focused, as you can see here, on all these other peripheral services, things that we might call recovery capital or social determinants of health. And there's been a cadre of these recovery support services that have augmented clinical services and have been part of the system of care now that have emerged and grown across the country, which are supporting people in recovery. What's interesting about many of these is that they weren't professionally engineered and directed to begin with, much like mutual help organizations like AA. They came rather from people who were suffering from these disorders themselves. They recognized a need which was not being met by clinical services alone. And so they have created, and spread these models of care around the country that can help people. Mutual help organizations, of course, is the oldest, most notably Alcoholics Anonymous, which started back in the 30s. And then that 12-step model was used as a template to address many other drug problems, of course, as they came along, different epidemics, as well as other compulsive behaviors. But there's been other models of recovery support, such as peer support outside of mutual help, including recovery coaching, recovery residences like Oxford houses, recovery community centers, which we've just finished a big study on, looking at how these recovery hubs in the hearts of communities can provide access to jobs, friends, housing that can help support recovery. And then there's been supports in educational settings, including recovery high schools and collegiate recovery programs, all intended to provide indigenous recovery support in the areas where people find themselves, in the locations and venues where people find themselves. So we can think about recovery support services as, of course, the idea with mutual help groups, recovery residences, recovery community centers, as ideally leading to remission and resilience, again, protection against relapse. And that is mediated by access to recovery capital, which produces this biopsychosocial change, which then leads to remission. And so what are these services that have come about? As I mentioned, most of these are free or very low cost, and they have high extensity, low intensity, but high extensity. This is important from a societal perspective because we know that the cost, of course, of the economic burden attributable to substance use disorder is very high, about 600 to 700 billion a year in the United States across alcohol, illicit drugs, and now, of course, prescription opioids. And we have money, of course, to pay for treatment, to provide treatment, to appropriate for treatment. But I think a rational national response should include all hands on deck. It should be about how can we best utilize the resources that we have to address this particular problem, in this case, substance use disorder, which is highly prevalent. Because there's many other diseases and disorders also vying for care, which are also very worthy of funding and appropriations as well. So as a society, it makes rational sense to try and think about, well, what do we have at our disposal? How can we maximize the utility of these organizations and entities that can support people and prevent them from essentially using more expensive models of care, like emergency rooms, overnight acute care stays, and so on. So mutual help organizations, I'll mention a few of these, which have shown not just to be effective, but cost effective. I'll start with mutual help organizations because they're the oldest and the largest by far, most notably AA and NA, other 12-step organizations also. And then more recently, other secular organizations like Smart Recovery. There's a lot of them about, of course. There are about 65,000 AA meetings alone in the United States. In Massachusetts, where I live, there's about 2,800 meetings within a 45-minute drive of my office. So it's a huge density. That's per week, 28 meetings per week, 2,800 meetings per week within a 45-minute circumference of my office. So that's a high density of recovery resource that's indigenous, that's freely available. Now, this high density of mutual help in the form of 12-step in particular has resulted in clinical linkage treatments designed to facilitate involvement in them. So the idea here is that to develop a clinical strategy which links patients during the active clinical phase to these free, ubiquitous, long-term recovery support services in the communities in which they live. And these are known as 12-step facilitation treatments. And we just published a review, a systematic review through the Cochrane Library, which is considered to be the gold standard in academic medicine of rigor, scientific rigor pertaining to any given clinical intervention. And then what we did was looked at the clinical efficacy of 12-step facilitation interventions and Alcoholics Anonymous for alcohol use disorder. So we conducted a very rigorous review. And what we found was, interestingly, that AA and 12-step facilitation treatments are at least as good as anything else. And they are better at producing higher rates of abstinence and remission compared to treatments like cognitive behavioral therapy or motivational interviewing. Importantly, also, they substantially reduce healthcare costs. So when treatment programs or therapies implement this linkage to AA, in this case for people with alcohol use disorder, they produce at least as good outcomes. They produce higher rates of abstinence and remission and reduce healthcare costs substantially. In fact, when we estimated in this study, we reckoned that if every clinical service were to provide linkage for those with alcohol use disorder to AA, we would save about $10 billion alone just in healthcare costs and improve outcomes substantially in terms of higher rates of remission. How do we know it? How does it work? Well, we know that these 12-step facilitation treatments work. How do they produce higher rates of remission? Because they link patients to AA. That's been established scientifically. Now, what does AA do? We've also found scientifically established that AA mobilizes these same mechanisms which are mobilized by formal treatment, except it does so over the long term in the communities in which people live for free. So what's good about AA and groups like it is that it tends to mobilize these social network changes, cognitive and behavioral coping skills, as well as reductions in impulsivity and craving, and increases in spirituality, which can help people cope with stress. It does so, it mobilizes these mechanisms over the long term, which are similar to those mobilized by formal treatment. So we've learned a lot about mutual help, particularly AA. Other groups, of course, other entities like sober living environments are also ubiquitous, and probably they are the next largest recovery support service outside of mutual help. And these have taken the form of now called recovery residences. And they can be short-term, medium-term, or long-term. And many of them are self-governed, like Oxford groups, Oxford houses, and shown to be effective and cost-effective. So we know from high-quality studies now, including randomized controlled trials, that these, when we randomize patients to go into a sober living environment long-term for a couple of years versus back to their home environment, wherever that may be. We know that in randomized studies, including this one here, depicted here, it results in higher rates of remission, lower substance use, higher employment, and lower arrests and reincarceration. And you can see the magnitude here is quite large and clinically significant. Also, when we look at the cost effectiveness, again, like AA, like 12-step facilitation treatments, the cost effectiveness of recovery residents is dramatic. In this study, there was a savings of about $30,000 over a 2-year period per patient when they were randomly assigned to the recovery residents. So not only did they have better outcomes, but they reduced societal costs by $30,000 via the ability of recovery residences to increase remission and reduce criminal recidivism and expensive healthcare utilization and improve employment. Now, there are some clinical models also of long-term recovery management, and I'll just show you one of them, which is kind of highlights the notion of treating addiction as a chronic illness from a clinical perspective. And this was done by Michael Dennis and colleagues in Illinois. And they randomized patients. What they were trying to do here was look at if we treated addiction like we would treat diabetes or hypertension as a chronic illness, where we do checkups every now and again over the course of a 4-year period. And this is what they did. They looked at the course of a 4-year period post-stabilization, so people were detoxified, stabilized, and then randomized to treatment as usual. Everybody got their usual treatment, mutual help, aftercare appointments and so on, continuing care appointments. But here's the thing. So half the patients were assigned to just a quarterly checkup with an assessment, but no feedback and no conversation. And half were assigned to a quarterly checkup. And if they had relapsed or were at risk of relapsing, they were linked to somebody who helped them get back into treatment. Okay, so that was the difference. One got a conversation based on the assessment data. The other one just got the assessment without any conversation. What did they find? So what they found was that people who got the assessment every quarter, who were at risk, and also got the conversation, the linkage back into treatment, got back into treatment 3 years earlier than people who just got the assessment without the conversation, the linkage back into treatment. So quite amazing that a very low intensity but high extensity intervention was able to produce such a large magnitude effect in terms of getting people back into treatment who needed it 3 years earlier than people who just got the assessment without the conversation. It resulted in higher abstinence rates, and also it was shown to be cost effective. So even though it costs more to implement it, ultimately the savings were greater when you did so. One of the last things I'll mention is recovery community centers. We've done a lot of work now on recovery community centers, and the National Institute of Drug Abuse have just funded us to build infrastructure for research in this area. So they have really valued this area of recovery community centers, I think in part because recovery community centers are designed to be locatable sources of recovery capital in the hearts of communities for people to access jobs, housing, recovery peer support, recovery coaching, learn how to put a cover letter together, get a job, find employers who will take people with prior drug convictions and so on. So they're perceived to be extremely valuable venues for providing this access to recovery. And we've published now several papers looking at the results from our initial study, which was conducted, which included Connecticut, the recovery community centers in Connecticut through CCAR, as well as across New England and New York State. So we included about 36 centers in total across New England and New York. Now, this was done a few years ago now, and as you may know, these centers are rapidly expanding. Right here in Massachusetts, for example, they've gone from 5 a few years ago to 26. So, and they're state funded here. So they've exponentially increased here in Massachusetts. In our small state of Massachusetts, we have 26 centers of these recovery community centers. So they're growing gangbusters, not just here, but all around the country. And I think because, as we say here in this paper, they provide one-stop shopping. Maybe that's a bit of an exaggeration, more of a catchy title, but I propose anyway that they provide one-stop shopping for recovery. Let me show you why. Is because we know that recovery community center duration, how long people participate, is associated with recovery duration. So, no big surprises there. The more you go, the more likely you are to be in remission and to be in sustained remission. That's what we would hope. But what is interesting about this preliminary study is the mechanism through which that works. What we found is that greater participation in these recovery community centers resulted in higher levels of recovery capital. And that higher level of recovery capital was associated with increases in self-esteem, quality of life, and lowered psychological distress, which are all associated with recovery duration. Most notably was that recovery community center duration was not associated with increases in recovery social support specifically, even though that was very present and a major component. It was not something that co-varied with RCC participation. So what it suggests is that recovery community centers provide something unique that is not provided by mutual help organizations or by clinical treatment. In other words, this is supporting the express purpose and rationale for recovery community centers. So what do we know about the quality of evidence for these different entities? We did a review for SAMHSA a couple of years ago now, which was a systematic review of these 6 areas. And what we found was generally few studies in general for the newer recovery supports, as you would imagine. But we did find strong support for mutual help organizations, particularly AA. That's where most of the research has been done, where there's been a large quantity of high rigorous research, which we summarized in that Cochrane report I mentioned recently, which came out this year in March. So there is strong support for AA and 12-step facilitation treatments which link patients to AA. There is fairly moderate to strong support for clinical models of long-term recovery management. In terms of peer-based recovery coaching, there's only a very small amount of literature, empirical literature right now, even though studies are being done to look at recovery coaching. Recovery community centers, again, a small amount of study, hopefully going to increase over the next 10 years. Recovery residences has more evidence available with moderate to strong support for the efficacy of recovery residences. And then education in recovery, recovery-based education like recovery high schools and collegiate recovery has started to be studied, but has very few studies and only weak to moderate support for its effectiveness. So when we look at, when we zoom out and think about, you know, where we've come from, where we are, where we're going, what we've learned, I think there's some things that we can conclude. We've learned a lot. You know, when we zoom out, yes, we've got a long way to go. We've got a lot to do, of course, but let's take note of the things that we've learned as a result of what we've done. We've done a lot. We've put in a lot of money and a lot of energy, resources to address and understand the etiology, epidemiology, typologies, treatment, prevention of substance use disorder, and we've learned a lot. We've developed lots of acute care paradigms which can put the fire out. But now I think we've learned that, yes, we can put the fire out. That's fantastic, and that's very important because we can save lives with proper detoxification, stabilization. But now we have to figure out, how do we help people achieve and sustain remission? How can we shorten that course to remission? How can we help people achieve stable remission sooner and improve their recovery capital, quality of life, self-esteem, and indices of well-being? I think we can understand it from theories which have been proposed in other areas like allostasis, like general adaptation syndrome, and so on. And we can use some of these theories of social buffering and dopamine D2 receptor changes that may function as a function of social integration and recovery support. That those things, the things that we don't ordinarily and readily associate with brain changes, actually do change the brain, and that they help people recover, not just in psychosocial ways, but in biological ways also. And I think because of this and these things we've learned, there is a new recovery science that has emerged and is emerging, which is how can we shorten that time to remission? How can we mobilize and help people sustain remission quicker and over the long term? And I think that's where we're at. So I want to thank you for, I'll leave that up, but I'll thank you for listening and for your attention. And I think we have about 15 minutes or so for questions.
John, first of all, thanks very much. We really appreciate your time. And I know I've gotten a lot of comments so far of folks saying just how happy they are with what you've been able to provide them. Folks, I'll just say we do have some time, as John said, for questions. You can utilize the Q&A feature at the bottom, bottom right of your screen. But we actually already do have some questions, and this comes from Judith. Can you please speak to recovery supports within high schools? Is there any current research? Are the interventions focused on prevention or recovery and treatment?
Both. So there have been initiatives nationally and regionally looking at prevention and early intervention or secondary prevention. So there have been efforts to provide, for example, screening and brief intervention in schools, in high schools, as a universal prevention strategy in some states, including in Massachusetts. So there've been pushes to do that. Where there has been more focus has been on recovery high schools in terms of research, looking at the effectiveness of providing a recovery supportive environment among individuals leaving treatment, adolescents leaving treatment and going back to an educational setting. So there've been some very good quality studies now conducted by Andy Finch and Paul Moberg and colleagues from Vanderbilt, showing benefit, basically reducing the risk of relapse in half when adolescents go into a recovery high school versus going back to regular high school. So there's some good news there in terms of these environments can be effective. The question is, can they be, are they something that can be supported and funded, and are they cost effective over the long run, or do we need to develop something else? So more is going to be learned in that regard.
John, thanks. We actually have another question here. Are we losing access to recovery capital during the pandemic? Any thoughts on how to address that?
Well, yes, I think that's a great question. Of course, it's something that we've all seen and heard is this inability to access certain aspects of recovery capital. I think one of the good news is, and I think it's particularly true for new people starting recovery, where they don't have the benefit of maintaining relationships with people perhaps they know in recovery via mutual aid or other entities through recovery community centers, but rather people starting a recovery attempt. Very difficult for those folks to, that's where I think it's really been difficult, is for the new folks to really get connected with recovery support services and treatment and the things that they need. For people who have already got a foothold in recovery, and even in early recovery, they've been able to transition to these online recovery support services, including telemedicine and mutual aid. So that's been definitely able to happen, but I think it's been toughest for those who are trying to get a foothold right now in recovery.
John, thanks for handling that one. We appreciate it. And just a reminder to folks, I do have just another question, but by clicking on using the Q&A feature at the bottom right hand of your Zoom screen here, you can ask a question. I do have some folks in the chat screen in the participant list who've raised their hands. The best way is to ask your question through the Q&A. It's just a lot easier for us. And John, here's the next question. With regard to prevention in high schools, actually it's a statement, you may want to look at the RAM Council in New Canaan, Connecticut. That I thought that was a question, John. I'm sorry, it's a comment, but something, especially for our folks who are viewing this here locally in Connecticut, that may be something that's worth looking at.
Right.
We have another question. It's actually a housekeeping question. Will the PowerPoint be made available? We can certainly do that. We have everybody's contact information, so we can definitely do that without a problem.
Mm-hmm. Yeah, that's fine. You can. The best way to do it is just make it into a PDF and send it, because then it's rather large right now, but PDF is more portable.
Right. Perfect. Perfect. Other questions? Are there other questions? All right. Well, it looks like, John, we might be all set here. Folks who have attended, if you do have any follow-ups, by all means, you can reach out to us. I'll be providing my contact information. You can certainly use that. In the meantime, we want to thank you again. HighWatch especially wants to thank John for being here and just being so engaged with us and offering his thoughts and his insight into all of this. John, we really do appreciate it. Thank you very, very much.
Yeah, you bet.
And folks, you'll be hearing from us shortly about our next webinar, which will be happening. We're going to skip August, but we'll be back with you in September. Thanks very much.
Thanks, John.
You're welcome.
Speak soon.